Healthcare remains a significant challenge around the world, with half the planet's population lacking access to adequate medical care. Yet the technology and resources are there. The US alone donates more than $250 million and thousands of physician hours annually to short-term medical missions. But significant inefficiencies exist, causing unnecessary suffering. We believe this is a solvable problem, and that we can learn from models like the world's financial markets, which utilize big data real-time to facilitate the flow of capital. What if we could leverage technology to better match needs and resources and reduce the inefficiencies in the delivery of healthcare? What if we could use big data to make the invisible visible and see where the need is greatest, and then deploy those resources where they'll do the most good? We believe this is possible. The Virtue Foundation Data Mapping Initiative is a new tool that pulls data from myriad sources such as social media, detecting patterns through natural language processing. Satellite mapping providing geospatial data on infrastructure, including roads and building heights, and then uses machine learning algorithms to deliver predictive analytics that match volunteers with the places, the projects, the patients that have the most need and can most benefit from their skills. Volunteers can use this technology to search for their specialty and indicate their preferences, and then learn where they will have the most impact. The result? Countless data points analyzed, thousands of doctors deployed, millions of lives impacted.
Thank you for having me today. I'm Dr. Joan LaRovere. I'm a pediatric cardiac intensive care specialist at Boston Children's Hospital on the faculty at Harvard Med School, but also co-founder of Virtue Foundation. And I like to begin with this video to kind of orient you to the type of work that we're doing at Virtue Foundation and our vision, making healthcare more efficient and accessible to those most in need in low and middle income countries. And it's the delivery of this work, but it's also the use of data science for the better optimization of the delivery in this work. And I'm quite proud of that video because that's not stock photo, but photo of all our medical teams delivering surgical and medical care on the ground. And it was on one of those trips that my colleague, Dr. Ebi Elahi, an oculoplastic surgeon at Mount Sinai, and also part of the founding team of Virtue Foundation, came up with this vision. He thought we should be applying data science at scale, at enterprise level, to make the invisible visible in 2010. So nobody understood what we were talking about, and it was about 2013 when I first found Javier, and Carto had a different name, and we started exploring this vision. It's incredible to see sort of where we've come over this time period. And Dr. Elahi asked this question: how do we translate what we know, what we see with our eyes and our ears on the ground, into information that can be analyzed in a situation where it's hard to get granular data, and action on it from my laptop in my living room or in my medical office? And really, that's been the goal that we've been on now over this past decade, reducing frictions and making it easier for more physicians to engage in this work. The capabilities in the data science had to catch up. They finally have. And we're now in the process of building a platform that's enterprise grade for this information in low and middle income countries. And it's this I'd like to share with you a bit today. Hang on, let me see how I can advance this. Okay. Next slide. Is this one? This one. Great. So the global healthcare landscape, it's a very complicated landscape, and it's plagued with information asymmetry. Dr. Elahi likes to call it a lemon market. Those that are most in need or the least able to tell you they're in need, And those that can help deliver care, there's so many frictions to getting involved. So how do we make that easier for both sides to make themselves known? And that was our original approach, creating the sort of Match.com for physicians and healthcare professionals. What's interesting is along the way, we found that governments also were quite interested in this data. We work quite a lot in Ghana, Mongolia, and many other countries, and when we present this to health ministers and others in these countries, they now can see the use cases and are asking us to think about solving from here. As are pharma companies and others who are trying to think about how do we get this care to those in need when it's so hard to access data and understand the supply chains. And surprisingly, there's no single repository for this information. We really searched. We have special consultative status to the United Nations. We went to the UN, to the WHO, to all these places to try to understand who's working in the landscape, who are the healthcare NGOs, where are they working, and where are the hospitals and healthcare facilities? What are their capabilities? How many ORs do they have? Do they have a blood bank? Is there an ICU? Is there advanced imaging? What are the specialties? That data is really not easily accessible. And we started to use AI and ML and started to extract this data, initially from web scrapes and built on from there. I had another another slide set. It didn't seem to get loaded. I could have shown you more of that. But we built that repository. So we now have, for 72 low and middle income countries, a complete data set of all the healthcare NGOs and hospitals in 72 low and middle income countries. We published that in November of 2021 with Taylor & Francis, one of the leading healthcare publishers, and had an accessible platform where you could go more deeper into the data from the book. This is showing how we trained the ML model for nonprofit website classification. It was the beginning of COVID, so we were able to use our surgical teams. So chiefs of ophthalmology and neurosurgery, this data was validated by people who it's very hard to get their time, suddenly had time, and really helped us to validate this data set and codified that into a couple thousand healthcare NGOs and ranked them in terms of the type of work that they are doing. We had a similar process for hospitals, building on the OpenStreetMap data set, which is wonderful, but at the same time not very specific. And pharmacies are the same as hospitals, so you can't really orientate yourself if you're a surgeon and you want to go do a cataract repair based on OpenStreetMap. So we then further customized that using filtering curation to a data set of 37,000 hospitals. Let's see if it's, no. There was, I'm trying to go backwards. There was another slide to show we've also built a beta version of an online platform, vfmatch.org, where you can access the data set for the healthcare NGOs, the hospitals, some country data, and the matching platform that I spoke about, sort of the Match.com for healthcare professionals, which, although in beta and not fully publicly launched, is actually making matches as we speak. So it's fascinating to see this coming to life. And we're now using Gen AI techniques to enrich and keep this data set continually up to date. So it's very exciting to see that new capability coming into it. Once we had this foundational data set, the goal was then to couple that with other layers of disparate data and start to answer some key questions. The first one we wanted to start with was thinking about optimization and efficiency as sort of where are the medical deserts? Since if we're going to deploy people, we would most like to deploy them to the largest populations with the least access to care, which would be these medical deserts. How do you identify them and call them out so that the people and resources can go to them and have the greatest degree of impact? There's 143 million surgeries in the world that aren't done every year. We've found that from the Lancet Global Commission on Surgery. We wanted to start to identify these are the spots where those 143 million people live. And if you are a physician or a surgeon and you'd like to get involved and help provide access to care in those areas, here's how you can do it. I'm going to come back to this at the end, that once we identified the medical deserts, we've put together a couple of use cases that I'll also explore with you in terms of how do you start to change the shape of them once you identify them. So the first thing we did was create, I'm giving you Ghana as a sample country. We've done this and working on doing this across all 72 countries. But first thing we did was develop a speed map. So from any point within the country, what is my speed to hospital facility? So that speed map is coupled here with the hospital data set for Ghana. And you can see the dark areas are 4 to 8 hours to get there. The whiter areas are 5 to 10 minutes. But just because I can get to a hospital doesn't mean that that hospital has the capacity to take care of me. So we started looking at an accessibility analysis. So when you look at the dark green areas, the healthcare and the hospitals that are there are quite accessible to you if you live there. But when you start looking more yellow and red areas, that's where there's a larger population, those darker red-brown areas, that do not have access to care. We looked at this across 3 different visualizations. So there's the geographical analysis. The middle is the zonal statistics. So this is by district. And it's the way a politician might look at the data set, which is quite important when you start thinking about creating new service delivery in ophthalmology or building a new healthcare facility. These things are often based upon political lines. So it's important to look at, and those dark areas in green are where there's reasonable access within those districts, there's capacity. And the lighter green moving up to the dark red is where there's the least capacity for that population. And the final analysis is quad-tree representation. So the smaller, the darker the box, the larger the population that is not served. I don't have a lot of time in 15 minutes, but just to say, we've done all of this analysis within the country for all of the specialties as well. So for neurosurgery, for cardiac surgery, for ophthalmology, for renal disease, so that you can start to get a real true picture, because a hospital alone is not enough. You need to know that that hospital is going to be able to take care of the need that you actually have. And if you're a physician that wants to volunteer, you need to know that a hospital has the capabilities for you to perform that surgery or that medical procedure safely and effectively for the populations that live there. So moving on from sort of this identification of these medical deserts, using more traditional data science tools, we partnered with DataRobot to start to use machine learning and identify optimal locations. Initially, looking at this for new hospitals as a starting point, since this type of methodology could be used for other things like where should we build the next neurosurgical capacity within our existing facilities, since that's a lot cheaper than building a new hospital, or a new cardiac surgery service. But just to kind of lay the groundwork, we started to look at identifying these optimal locations. And we trained the model. These are showing some of the maps that we trained it on: elevation, population density, land cover, roads, and the current existing hospitals. We trained the model, don't put a hospital on a highway, don't put the hospital on top of a mountain, don't put the hospital in the middle of Lake Volta. And this is just a schematic of the multimodal approach that we took in partnership with DataRobot in creating this. And this is the output. So it can be a little bit confusing. The red dots are the current hospitals and where they exist. Those green dots are the locations within the hospital, within the country where a hospital could be built. And we just published this work. Some of the volunteers from DataRobot are co-authors on this paper with us. and it's being presented at IEEE in Copenhagen this week. This methodology is a way to crack the problem. So those green dots are all the locations within the country where a hospital could be built. And then we started to ask, okay, that's great, but I'm not building in all those areas. Where are the optimal locations? And we first asked it to go through the first 100. And I think one of the things that we found that was really fascinating in looking at both those initial maps that I showed you and in this optimization model is that you kind of expect there's going to be some of these remote, I don't know if I have a light on this. No, I do. So around the Lake Volta region, hard to access place, there's actually a large population. You kind of think that's not surprising. What was also quite interesting is that places where hub cities like Accra, Tamale, Kumasi, right? That's Accra's #1, Kumasi's 2, Tamale's #3 city in this country. We saw the same thing replicate in Mongolia as well, that in the suburban areas of these low and middle income countries, there's actually tremendous need and insufficient capacity, particularly surgical capacity. So that was a little bit counterintuitive to us. So we found there were two kind of solution areas, both some of these remote regions of large population, which are medical deserts, and then suburban urban hubs were also medical deserts. So these are two places that need to be tackled within low and middle income countries in terms of providing additional care. And we've learned all this from the data and from the machine learning. We then asked the model to rank the sort of top 20 of those, and we did it ranking it in a list order. I would love to start to add in the solar API that we heard about and some of these other pieces of data as we continue to refine the locations for new hospitals. And along that vein, I want to talk about sort of one use case that we have developed. And we've developed this not for just Virtue Foundation to use it, but for other partner NGOs, governments, even corporations to use in terms of getting more efficient access to care. So I had better slides than this, so I really apologize. But one of the things that's an issue is obviously there isn't the workforce, there isn't the supply chain. I mentioned to you there's 143 million surgeries that don't get done. That same global commission estimates you need 5,000 per 100,000 population. We also know that data in all of these countries. So it's only 869 within Ghana, 284 per 100,000 in the children. There's big need. And we have that for each of these countries and can start making estimations. And then coupling that, this is another partner NGO founded by a surgeon out of Mount Sinai, chief of surgery, where they built a state-of-the-art ambulatory surgical center to tackle this problem within Uganda. And they put a fiber optic cable in so that I can real-time assist a surgery from Boston or London or New York with the Ugandan surgeon. And they also made it solar powered. So that's why I would like the solar API plugin. Because many times I've been in these locations and halfway through a surgery, we're operating by the flashlight of 3 Apple iPhones. So having that consistency of electrical power, it's tackled a lot of those really complex, but at the same time, this is an elegant and efficient solution. So they just decided to put it in this location. He was fascinated by what we've done with Virtue Foundation and would like to use that data from Ghana to start looking about building a second facility, but this time being informed by the data and this model. And also using our kind of VF match, match.com approach to also being able to recruit more workforce to help remotely or in person. The second use case I'd like to just touch on, so this is building capacity. The other issue we find is access. And deploying tricycle ambulances is another use case for our foundation, which we have done in partnership with Moving Health, which is an NGO that spun out of MIT. Some women engineers have created these phenomenal tricycle ambulances. We invited them to come to northern Ghana and work with the local teams and design and build these locally. And it's been incredibly effective in gaining access to healthcare facilities where terrain is really challenging. And one of the things we've been doing is using this map to identify optimal locations for where the ambulances should go. And we now have a dozen of these in place. What's interesting is 60% of the rides are pregnant women who want to deliver. And there's a high maternal mortality rate from hemorrhage, from maternal hypertension, from sepsis. And the biggest problem is getting to a hospital in time. So this has been fascinating. We have remote sensors on these ambulances. We're collecting this data. And we are looking at expanding this to this entire Upper West region. And what's fascinating to me is what this data can do. Is that we looked at this entire region, and for $3 a person per year, so it's less than $1.5 million, 10,000 women's lives can be saved. So I think that the impact of data science and what we can do is we start to look at identifying where these medical deserts are, and then think about how we can reshape them based on the data. And it's not all going to be done by one organization or institution, but that we all can action upon this sort of data and really improve and save lives. So thank you very much. I had a slide with my contact details.